Okay, guys, so I have a short presentation today. I'm gonna review respiratory stuff, including obstructive versus restrictive, dead space, and then ventilation, which includes the minute and alveolar. All right, so to start off with obstructive lung diseases. So essentially what happens or occurs in obstructive lung disease is that air becomes trapped inside the lungs, and so patients can't get as much air out, or essentially they cannot fully exhale anymore. So like I said, once they cannot fully exhale, and oops, typo, that essentially increases the residual volume. Remember, the residual volume is just going to be the air in the lung after a maximal expiration. And so because the residual volume increases, that also leads to the FRC, or the functional residual capacity, to increase. The functional residual capacity, again, is the residual volume plus the expiratory reserve volume. So this is going to be a total of the volume of gases in the lung after a normal expiration. And essentially at the end, that's also going to lead to an increase in the total lung capacity. So again, keep in mind, the air is trapped inside the lungs. It's not being fully exhaled, so all the volumes are increasing. Vital capacity, or also the FVC, is the total of the tidal volume, the inspiratory reserve volume, and the expiratory reserve volume. It essentially tells us the maximum volume of gas that can be expired after a maximal inspiration. So this in a obstructive lung disease patient stays pretty much normal, unless there's a concomitant restrictive process also present, meaning that you have an obstructive lung disease with also a restrictive lung disease process taking place. So overall, in the obstructive lung diseases, the vital capacity stays normal. The tidal volume, and then I just put AKA, the volume tidal is just the equation form you'll see that tidal volume in, remains normal, but it takes longer to, the tidal volume will be normal, but it does take longer to exhale than normal. So that would be the exhalation longer for normal would be if there's, again, a restrictive process taking place at the same time. And then overall, at the end, significantly there is decreased FEV1, so the forced expiratory volume at 1 minute. And there's also decreased functional, or FVC, volume capacity. So overall, that makes the ratio FEV1 to FVC less than 80. So to give you guys a more visual, again, in the obstructive disease, the the residual volume is going to increase. And as a result, the FRC increases, which leads to the total lung capacity to increase. The vital capacity, or the FVC, which means the same thing, stays relatively normal, unless, again, there is another restrictive process taking place at the same time. The tidal volume here remains normal, and that would make sense as the residual volume is increasing, and like we said, the FRC makes up the ERV plus the RV residual volume, so hence it's also going to go up, making the total lung capacity go up. So the vital capacity and the tidal volume stays normal. And so that would be that. And then to show you guys one versus the other. So on your left-hand side, this is the normal. Looking a little bit closely at the FVC, the vital capacity, compared to the forced expiration at 1 minute. So this would be normal. But in here on your right-hand side is the what you would see in an obstructive lung disease. So you see that the forced expiration at 1 minute is smaller. And but the FVC stays pretty, the vital capacity stays normal. So if you were to compare this at a ratio, it would be less than 70% because the forced expiration at 1 minute has decreased significantly, and the vital capacity has decreased very minimally to little. So overall, that's going to give you a less than 70 ratio. Does that make sense? Mm-hmm. Anybody have questions or anything they want to add? Alrighty, so to give you guys a little quick question, what would happen to the total lung capacity and the residual volume in a patient with chronic bronchitis? Sorry, I meant to mention these real quick, but I think we're quite familiar in that chronic bronchitis is representative of what lung disease?
Obstructive?
Yeah, exactly. And can you guys name me a couple more that fall under the obstructive lung diseases?
Emphysema and asthma.
And one more?
Bronchiectasis.
Exactly. Good job. All right. So, okay. So back to the question. Can you guys tell me what's going to happen to the residual volume again in a patient with chronic bronchitis or an obstructive lung disease?
Increase.
Exactly. And that would make the total lung capacity
increase.
Mm-hmm. And then the expiratory reserve volume would be
decreased
or normal.
Oh, expiratory reserve.
No. Yeah, so it would be normal because sure, decreased to normal, if you want to say that. And again, that being the fact that
patients have difficulty exhaling.
Right. Yeah, exactly. The air is trapped inside, so exhalation is difficult, hence why it's going to be, I guess, decreased to normal. All right. So moving forward, restrictive lung diseases. So in this patient, these patients cannot fully inhale because the lungs don't expand fully or because they are damaged or restricted. Can somebody name me some of these diseases or some of the diseases that fall under the restrictive lung diseases category?
Fibrosis.
Sorry, say it one more time.
Fibrosis.
Necrosis, okay.
I've had pulmonary fibrosis.
Oh, pulmonary fibrosis, yes, exactly. Anything else that you guys can think of?
Sarcoidosis.
Yep, sarcoidosis.
Pneumoconiosis.
Exactly, pneumoconiosis, right. Okay, so moving on, like I said, there's less air in the lungs for the patient to exhale since they really can't fully inhale anything. Okay, let me go back one step. So because they cannot fully inhale, and the lungs are restricted, so they can't expand, the patient's going to have a decrease in the inspiratory reserve volume and tidal volume. And as a result, since there's less air in the lungs to begin with at the breath, they're also going to have a decreased expiratory reserve volume. So what you don't inhale, you can't really exhale. And then that also leads to a decreased functional residual capacity. So if you have decreased, putting this all together, IRV, tidal volume, and FRC, then that overall is also going to lead to a decrease in the total lung capacity. Again, considering that the inspiratory tidal volume and expiratory reserve volumes are decreased, that's also going to significantly end up decreasing the FVC, which I'll show you in the spirometry graph in a moment. And then most importantly, at the very end, since there's decreased forced expiratory reserve at 1 minute, our forced expiratory volume at 1 minute is decreased, and there's also a significant decrease in the FVC that leads to an actual increase in the ratio of FEV1 to FVC, so it'll be greater than 80. So to show you guys again, like I said, the patient in a restrictive lung disease cannot fully inhale, so therefore their inspiratory reserve volume, or what's inhaled, is decreased, and their tidal volume is also decreased because there's less air that even entered the lung to begin with. That's also going to make the expiratory decreased, and the overall FRC then, which is made up of the expiratory reserve volume and the residual volume, are both decreased, making the FRC also decreased. And yes. Sorry, and the FVC is also, so the vital capacity, or the FVC, will also then be decreased since the FRC is decreased. And we're going to take a moment and look closely at the forced expiratory volume at 1 minute, which makes up that ratio. So are we good so far in terms of just understanding how those decreased values of the volumes make sense in a restrictive lung disease? Okay, so then taking a little zoomed in picture at the forced expiratory volume at 1 minute, and then the FVC. Again, the left-hand side is showing our normal, but the right-hand side is showing what it would look like in a restrictive lung disease patient. So here, the expiratory volume at 1 minute decreases, but the FVC, or that vital capacity, decreases even more compared to the normal. So if we looked at the ratio, we see a decrease in both, but more on the bottom than the top. That's going to lead our ratio to be greater than 80%. How does that sound for you guys? Good? Anybody want to add anything or anything? Okay, so now to apply this. Okay, oopsies. Well, here we go. So what would happen to the vital capacity and total lung capacity in a patient with borreliosis? So borreliosis is a what category lung disease? Exactly, pneumoconiosis. So then we said pneumoconiosis makes up the restrictive lung disease. So it is a restrictive lung pathology. And so what would happen to the inspiratory reserve volume?
Decrease.
And the total lung capacity, or volume?
That would decrease as well.
And the expiratory reserve? Volume.
Decrease.
Yep, because whatever if you're already inhaling low amounts, then you're not going to exhale anything more than that. Yep. And then the vital capacity would be, or the FVC?
Decrease as well.
Exactly. All right, so that wraps up my review on obstructive versus restrictive.
So restrictive, everything is decreased except the FEV1 to FC ratio is normal, because everything is decreasing equilaterally.
Yep. Or maybe normal to greater than 80%. The normal would be 70%. So I believe, or I've stuck to the rule of saying greater than 80% would be considered restrictive.
Basically, as long as it's not decreased,
right,
you can assume that, okay.
It's restrictive. Okay, yeah. Alrighty, so let me go back one. Okay, so the next topic I was going to discuss with you guys is dead space. So dead space is a physiologic dead space that includes the anatomic dead space and the alveolar dead space. So you can think anatomic as all the anatomy that takes place before we get into the area where alveoli come into place down into the lungs. So the anatomic dead space is the volume of air in the conducting airways that does not participate in gas exchange. So this is just the area where air comes in and out. And like it says, no gas exchange is occurring. It's not reaching the alveoli. The alveolar dead space is the volume of air within the alveoli itself. It does not participate in gas exchange. It's usually close to zero. So it's closer to the alveolar space, but again, no gas exchange is occurring. Okay. And then in healthy individuals, anatomic dead space is very equivalent or the same as the physiologic dead space number. Okay. So, with that. Okay, so when determining the physiologic dead space, the equation here, as you see, is telling us the tidal volume, or the VT, V sub T, times the partial pressure of carbon dioxide in the alveoli minus the carbon dioxide in the expired air, or the partial pressure of expired air, divided by partial pressure of, again, carbon dioxide in the alveoli. So I know that Divya has mentioned this before, but you can remember it as TACO, which is the T for tidal volume, PACO for the PA, PICO over PACO again. So that's just like the order. And again, physiologic dead space is equivalent to the anatomic dead space. It should be very much the same. And it's the dead space of the conducting airways plus the alveolar dead space. And so the apex of the healthy lung is the largest contributor of the alveolar dead space, volume of inspired air that does not partake in gas exchange. Okay, so then to give you guys a scenario here. Okay, so here we see that the alveolar CO2 is 40 milligram per mercury, and then the expired CO2 is at 28. So clearly we see a discrepancy here, and it is for us to determine where that remaining gas exchange is missing and where it is. So that discrepancy we can attribute to being in other areas or spaces of the lung. And this fraction here specifically allows us to determine how much air or gas has actually made it to the alveoli. So if we went ahead and applied the equation here, we can say the PACO is 40 minus the PICO, which is 28, over the PACO. So this gives us 0.3, which is equivalent to 30%. So then, so that gives us that, and if we, now we just need to multiply that by the tidal volume. If we took the normal values of the tidal volume, which is 500 milliliters, and we took 30% of that, that's going to give us 150 milliliters. So the dead space, normal dead space, physiologic dead space would be 150 milliliters. So yeah. And then remember the big A, it's not a worry here, but the big A represents alveoli, the little a is the partial pressure of CO2 in the blood. So they should be about the same if diffusion is occurring normally and is intact. So does that make sense? How does that sound for you guys?
Makes sense.
Okay. Oh, oops. Yeah, so the normal values, just to give you guys an idea, respiratory rate is 12 to 20 breaths per minute. Tidal volume is normal, 500 milliliters per breath, and the physiologic or the normal dead space is 150 milliliters per breath. Okay, so to give you guys a question here, how would the physiologic dead space change in a pulmonary embolism? So the picture here is just showing you that the vessel is blocked, you have a pulmonary embolus here, and so therefore blood is prevented from reaching the alveoli since we have a block here. And so if blood is not reaching the alveoli, there's no gas exchange occurring. And so if no gas exchange is occurring, what would happen to the physiologic dead space?
Increasing the amount of
Right, exactly. Yep, it would increase in amount, exactly.
Because you're just creating more area where gas exchange cannot occur.
Right, exactly. Does that make sense for everyone else?
Mm-hmm.
And again, remember the physiologic is supposed to be the same as anatomic, so, or, well, I guess anatomic, yeah. So it should be both about the same in the scenario. Okay. Okay, one more.
Did I get that?
Yeah, that's right. Yeah. Okay, so next question. A 21-year-old presents with central macular and papule lesions surrounded by a ring of erythema. He is treated with azithromycin and his condition improves. What changes in the physiologic dead space should you suspect during his initial presentation?
Are you implying that this guy's having a...
Okay. Here, let me help you guys a little bit here. So a central macular and papule lesion is indicating that this guy has erythema multiforme. With considering his age and that his condition improves on the medicine, we can most likely attribute that to indicate he has a Mycoplasma pneumoniae infection. So now thinking about the pneumonia infection, how does that affect the physiologic dead space? Well, pneumonia specifically is an infection of the alveoli, which causes air and space to fill with pus and inflammatory exudates. So air reaching the alveolus, but it cannot complete gas exchange. So now what would occur to the physiologic dead space?
So we're going to have an increase in physiologic dead space.
Right. So physiologic dead space is increased, anatomic is normal, alveolar is increased as air is reaching there, but no gas exchange is occurring.
Okay. Fun fact when it comes to lung pathology, specifically azithromycin of the macrolides is a bronchodilator as well as a anti-inflammatory. So azithro is your way to go when it comes to respiratory pathologies, specifically like you're showing pneumonia.
Good to know.
All right. Okay, cool. Yeah, that was a good fun fact. I like that. That was interesting to hear. Okay, so that wraps up my physiologic dead space. Anybody want to add anything on to that?
Nope.
Alrighty, so alveolar ventilation versus minute ventilation. So alveolar ventilation is the volume of gas that reaches the alveoli each minute. And so as you see, the equation here is the tidal volume minus the dead space times the respiratory rate. On the other hand, minute ventilation is the total volume of gas entering the lungs per minute. So this is going to be the tidal volume times the respiratory rate. So as you can see, the difference is that we are taking into account the dead space in the alveolar ventilation since the physiologic dead space does not reach the alveoli. So we're just not taking that into consideration when doing alveolar ventilation. So I think the best way to really understand this is perhaps put it into a question format. So if the tidal volume is 500 milliliters per breath and the physiologic dead space is 150, the respiratory rate is 10, then what would be the alveolar ventilation? All right, so here's the equation. Alveolar ventilation is the tidal volume minus the physiologic dead space times respiratory rate. So we have all the variables given here. I guess that's pretty simple. And that gives us, go ahead, sorry.
3,500?
Yep, 3,500. So yeah, that's just kind of as simple as it is. But I guess a food for thought type of thing to kind of differentiate the two, would alveolar or minute ventilation be larger? Considering the equations, essentially.
Minute.
Right. So minute ventilation is going to be larger since we're not plugging in the dead space amount. So yeah, that is all I have for you guys today. Short and sweet. If anybody wants to add anything, please do.
I think it was one of the Kaplan. It wasn't. Maybe it was Fisher. I think it was whatever the other physio guy was, because Fisher didn't do pulmonary in the older Kaplan videos. But I remember him saying that you can imagine anatomical dead space as when you hear the story of a kid that's trying to pull a prank on his friend by jumping in a pool and trying to breathe out of a hose, and the hose goes all the way down the backyard, and then you find out the kid is dead. It's because this kid is sitting there thinking he's breathing oxygen, but he's just breathing carbon dioxide because it's all anatomic dead space that he's breathing through. So that's how I always remember it.
Very morbid way to think of it.
Hey man, it's not all fun and games in medicine, so fuck it, I'll take it.